Welcome everyone to Einstein's Eyes, our YouTube channel. I'm Carl Rosen, an oculoplastic specialist in Anchorage, Alaska. I am an ASOPers member, American Society of Oculoplastic and Reconstructive Surgeons. My partner and friend and former co-resident at Montefiore Medical Center, Albert Einstein College of Medicine, is Jon Ditkoff, a fellowship-trained cornea specialist. John's in New Jersey. We're far apart, but yet we are joined telepathically. And today we're going to talk about tearing. Tearing is a common problem many people have. There are multiple causes, multiple reasons. John's going to talk about tearing from the cornea aspect, the anterior segment aspect, and I'll finish up simply with how I view tearing from a 50,000-foot view as an oculoplastic specialist. John, take it away.
So many patients will come in complaining of tearing one eye, both eyes, off and on, constant, and a lot of it is history. So someone says they're getting tearing that comes and goes. I know it's going to be most likely from their anterior segment or the front of their eye. It could be allergies, it could be dry eye. A lot of people don't realize, but dry eye can cause tearing because when the surface of the eye becomes dry, becomes irritated, and you get reflex tears. So oftentimes a lot of patients will say to me, I'm getting tearing off and on in one eye or both eyes. First thing I want to consider is dry eye. Next thing, maybe allergies. If the tearing is constant, it started suddenly, and it's happening only in one eye, that's when an antenna goes up. And I say, maybe this isn't from the anterior segment, which is the front of the eye. Maybe it's actually from a tear duct issue, like a blocked tear duct. And that's when I usually will refer my patient to my oculoplastic specialist. But if you're in Alaska, then I would send you to Dr. Rosen. So Carl, tell us what you do with these people with a blocked tear duct.
Absolutely. So I'd like you to refer to an image I have here. So here's a schematic diagram of the nasolacrimal system, which is the tear system. It's like a faucet. You make fluid to moisturize the cornea, which is part of the normal physiology. And then you drain that just like you would drain in a sink. You have a faucet, you have a drain. Here's the drain. This starts with the puncta, which
so Carl, one of the things I use a lot is faucet drain. So if you were saying where's the faucet would be, show us where the faucet would be.
Right. So
top right, like that's producing the water. And
right.
Then the drain is where Carl was just starting to say it. Exactly, that's the drain.
So right. So as John was mentioning, here's the lacrimal gland. This makes the tears. There are also some other tear secreting glands called Krauss and Wolfring and these other things. You don't really need to understand completely, but basically it just moisturizes and makes fluid so that the eye is not dry and the eye works properly. It then drains into something called the puncta. Here you have an inferior and a superior puncta. You have a tear lake, which I always assess, because if the tear lake is high, then there is a problem. And we also assess the pump, which is the blink mechanism. So the pump or the blink pushes the tears into this puncta, and then this canalicular system, this is the inferior one, this is the superior one, into the lacrimal sac, which is in the corner by the nose. Then it drains in a small tube to the bottom of the nose under something called the inferior meatus, and it cycles just over and over again. No one thinks about it. If it gets blocked, it can get infected, and that's a big problem. That's called a dacry cystitis. If there's a functional block, usually related to allergies, sometimes other medications, radiation, trauma from facial fracture, or even nasal or sinus surgery, then we have options. And basically two options that I talk about. I can tighten the eyelid to make the pump better, or I can create a new pathway called the dacriocystorhinostomy to allow the tears to bypass the nasolacrimal duct, which is blocked, again, usually from allergies. And that oftentimes, about 80–85% of the time, cures the problem. That in a nutshell.
When I send the patient to you, how do you confirm that they have a blocked tear duct?
So a couple of things. One, I look at the tear lake, like I said. Two, you can do something called a dye disappearance test, which you stick some fluorescein, which is this dye that you can watch. If it lingers and languishes and doesn't go anywhere, then you know you have a problem. Or you can do something called probing, and you can place a blunt cannula and irrigate the system. And you get a feel after about, 25 years of doing this, you get a feel for how much pressure you need to push the fluid. If the fluid just doesn't go into the system and just regurgitates back through the superior system when you cannulate the inferior system, then you really have a complete blockage, and there's no discussion. There's just one answer, and that's a DCR. So that, in a nutshell, is how we assess tearing from the anterior segment and from the oculoplastic perspective.
I would just reiterate, the most common cause of tearing is dry eye. And I know that sounds funny. My patients laugh all day. They think I'm a comedian, but I'm not a comedian. The most common cause of tearing is dry eye. When the surface becomes dry, it stimulates the eye to reflexively tear. I tell all my patients, it's like going out on a windy day and the wind is blowing across the surface of your eye, drying it out. What do? You start to tear. So if you're tearing when you're reading a book or watching TV or on your computer or driving at night, it's because your eye's open, it's not blinking normally, the surface is drying out and you start to tear. So if you use tears, that'll help it.
Right. Good job. So folks, we just wanted to give you a high level view from an anterior segment and oculoplastic perspective of tearing. Thank you, and we'll see you on the next one.